I was just going to say one thing as we start. These standards of care, they're put out every year, every other year by the American Diabetes Association. It's like 1,000 pages, and they're written for healthcare professionals. So what we've tried to do is go through them and tell all of you the important, up-to-date standards of care in many different categories. We have a lot of area to cover, but it's important that people with diabetes know, because then you can have a really decent conversation with your healthcare professional. And don't rely on them to follow up on all these standards of care. You need to do it and then create a conversation.
Yeah. So like Steve said, these are released every year by the ADA, and arguably one of the most important things they do. What is a standard of care? It's just if you were kind of practicing the best medicine possible, you would be adhering to all these guidelines. And there's a lot to it. We were talking about it used to be just kind of, just glucose management, how to control your blood sugars. Now there's whole chapters on, heart disease, liver disease, bone disease, mental health, technology. It just expands and expands. And, so I have to admit that I really went through these in detail the last, couple of days. I learned a lot.
I learned a lot,
yeah.
For sure. So
we picked out kind of 10 key topics from these guidelines, updates, et cetera. And we're going to start with topic 1, which is, I think if you don't hear anything else, this is probably the most important. It's the overall goals of diabetes are to keep people healthy and to live a long life. And there really are 4 key pillars in terms of diabetes health, that if you really kind of tackle these 4 things, it's not a throwaway statement. You will live a long and healthy life. So Eric can maybe throw up this graphic to show what the 4 different pillars actually are. But you can see 1 is glycemic management. We'll talk about what this means. Basically, control your blood sugars. Number 2 is blood pressure management. We'll talk about, again, the exact goals. 3 is lipids, aka cholesterol. And the 4th, or the final one, especially for people with type 2, is getting on medications that help with heart disease, kidney disease, etc. We'll talk about GLP-1s and SGLT2s. So again, if you don't take anything from this, what are your goals? And you should remember this when you go see your provider to kind of address these 4 things. You can take that picture if you want or write them down. But what is our goal for blood sugar management, Steve, for most people living with diabetes?
Yeah, for most people with diabetes, the goal is to get your A1C less than 7, which is an average blood sugar of about 150. Now, I know what a lot of you are thinking. What about time and range? 70% of your time or greater. The American Diabetes Association and our FDA, they're very, I would say, traditional organizations, and it's slow for them to make changes. So currently, your A1C should be less than 7%, not less than 6, like many of you think it should be. But if you can get it down to 6 without hypoglycemia, more power to you. And some of you can do that. And we applaud that as healthcare professionals. But the A1C, as you know, it doesn't measure how often you're getting low. And it's just an average. And that's why we're going to talk a little bit about technology as one of the 10 points we're going to cover. And we'll talk about the metrics that those can give you too.
Yeah. So another way to think about these pillars is the ABCDs. So A is for A1C. You want it generally less than 7. That requires a lot of work to get it there. It's not an easy to do thing, but if you stay on top of it, people can get there.
And keep it there.
Yeah.
That's hard too.
Exactly. So B is for blood pressure. So what's our goal for blood pressure, Steve?
Yeah, well, it changed. It changed. It used to be 140/90 if you didn't have risk factors or you're not on medication. But what they looked at tons of data, looking at hundreds of thousands of people, 130/80 or less. And that's the recommendation for people with and without diabetes. And blood pressure is so important because it's hard to describe it quickly, but if your blood pressure is high, it hurts many of the organs in your body, including your heart, your kidneys, and even your eyes. So it's really important. You all should have a blood pressure cuff at home. Don't rely on once in a while measurement when you go to the doctor's office.
And it's so common for, you go in, like somebody who puts you in the room, measures your blood pressure, and it might be high and you say, oh, I just drank coffee or I was just running around, like whatever. And honestly, as the provider, when we come into the room, we might not have that information right away and see it. So if there's something that is you notice is high, like definitely actually like proactively bring it up. And if it was high and you said you were running around, check it again. But my point is, it's so easily dismissed. It was high, let's talk about it next time, or it's just never even talked about.
You're
But
right.
it's so important.
Yeah.
It's easy to treat. The drugs we have for blood pressure are effective. They've been around forever. They're dirt cheap. So it's so important to address it.
I always say that your blood pressure changes like airline ticket prices and rent-a-car prices. It can change like that. That's why having your own cuff at home, either a good wrist cuff, make sure you read the instructions, or the arm cuff, you got to get multiple measurements. And if your blood pressure is always good, then you don't need to measure it that often. But you're right, Jeremy. It's so easily dismissed. Even at UCSD, I have to look around in the electronic medical records to find it.
Right.
So
A1C, A. B, blood pressure, 130/80. C is your cholesterol. And really what we look at is when you get your cholesterol, there's multiple things. There's usually the cholesterol, the HDL, the LDL, the triglycerides. You're thinking, how do I interpret this? Really kind of what we focus on the most, if we had to pick one, is something called the LDL. What I think of as L for lousy, or that you want it as low as possible. And we have new, frankly, very aggressive goals for what we want people with diabetes. This is type 1 and type 2, by the way, what we want their cholesterol to be. So we want your LDL, if you've never had any kind of heart history or whatever, to be less than 70. And if you've had any kind of heart attack or heart history, we want that less than 55. Now, the way that I think of it is that nobody is just walking around with an LDL cholesterol in the 60s.
Yeah.
So without medications. So I interpret this as, if you have diabetes, you need to be on a cholesterol lowering medication. And people get so hung up on, let me change my diet. I've been eating too many eggs or whatever it is. You can change your cholesterol this much by adjusting your diet.
Yeah.
So really, the change that you need is like cutting it in half kind of thing. And you have to use medications, I hate to say it, to get there.
yeah, both Jeremy and I are on, I'm on two different cholesterol medications to get to goal. And just to let you know, these goals have been lowered. Used to be less than 100 for everybody, and less than everybody with diabetes, less than 70 if you had heart disease. And they didn't just lower these ranges so they can sell more drugs.
Right, and that's important because the cholesterol drugs have been around forever. So is the blood pressure drugs. This isn't big pharma coming up with ways to sell drugs. These are all generic by the vast majority.
Yeah, and they've just shown over time, high cholesterol causes plaque buildup in your arteries, heart attacks, strokes. And so, and one of the other things they stress throughout the whole document, be proactive, go for prevention, and don't just be reactive and start treating after someone has a heart attack.
Yeah. The one thing I will say about these guidelines is that people with type 1, we always wonder kind of where we fit in this. A lot of time I see people that are in their 20s with type 1 diabetes, and they'll say, do I need my cholesterol, aggressively treated for the rest of my life? Personally, I think it's a good idea. I get very serious with my type 1s. Once they get into their 30s or so, then it becomes like, you really, really should think about this. In their 20s, if people are resistant to it, that's fine. But certainly if you have type 2 diabetes, everybody should probably be on a cholesterol med.
Yeah, for sure.
Yeah. So the last one, we're spending time on this because I do think this is important. A, A1C, B, blood pressure, C, cholesterol. And by the way, blood pressure and cholesterol are generally so much easier to treat than getting your A1C less than 7.
Yeah.
We spend an hour with patients, if we have to, talking about blood sugars and carb counting and what your diet is and just trying to get the A1C down. And it's so much easier to manage these things. So please, invest in addressing this, knowing these goals, taking medications if you need them.
Once you get them under control, like Jeremy said,
Yeah.
they can be pretty stable.
So, and then D is for drugs. So this is mostly for type 2, people with type 2, that these GLP-1 medications like Ozempic, Trulicity, Mounjaro are very effective in not just blood sugar control, but weight management, heart prevention, kidney prevention, and then the SGLT2 meds like
Good.
Farxiga and Jardiance. So the point there is that not all blood sugar lowering medications are created equally. you can get your A1C less than 6, but just taking insulin if you want for type 2. But these other drugs have additional benefits.
And what the American Diabetes Association did when they gave suggestions on which drugs to start off first, the first question they asked healthcare professionals is, do your patients have heart disease or risk for heart disease? And it's either GLP-1 or SGLT2. And then if the A1C isn't that goal, you do both. And that's unheard of because everyone always starts with metformin first. For many of you type 2s, I'm sure you all were started on metformin. They say actually go to these two drugs before metformin if you have risk factors. And the list of things that these drugs can help people with is just getting bigger and bigger and bigger. And wait till you see our next Newsy News broadcast, and we have Alicia Keys singing all the different benefits of the GLP-1s. So I'm glad that it's part of the pillars.
Yeah. So again, if you want to tune out now, fine.
No. I have important things to say.
No,
Don't say
the
that.
point is that like these pillars are really important, and that and these things for both blood pressure and cholesterol have changed. So technically, last year maybe you were fine, and now we're like, look, we need to be more aggressive with these things earlier. And I think both of us agree that that's appropriate, that people can get better blood pressure and cholesterol control without side effects, things like that. So what's the second topic? So now, not to scare you, we're going to get into a lot of different other areas that are associated with diabetes. Heart issues, bone issues, liver issues. And Steve and I always say, like, add it to the list, right? Another thing that we gotta, think about. So it's not to scare you that you're gonna get these things. It's just to be aware of them, that if you have diabetes, unfortunately, we're at higher risk for them. So the second topic is on heart failure. So how would you describe that, Steve? What is it?
Yeah, congestive heart failure, it's the single most common cardiac abnormality in people with diabetes, type 1 and type 2, not heart attacks that you might think. But basically, heart failure, the muscles of the heart pump blood around the body, and it doesn't do a very good job pumping. The heart muscles become weaker. There are a lot of other causes for heart failure, but nonetheless, the blood doesn't circulate throughout the body, and you end up collecting fluid, like in your lungs, congestive heart failure. You get swollen ankles. There's many other issues that you can get, and heart failure is a very a prognostic sign, meaning that once you have one episode, you're at risk for another. Every time you have another episode of congestive heart failure, a little bit more of your heart tissues die. So to screen for that, Jeremy and I were talking, we don't screen for it enough. We leave that to the cardiologist after someone already has an episode of congestive heart failure, but it's not a difficult test. We get an EKG. Everyone gets an EKG here and there. You can get an ultrasound of your heart, and they measure a thing called ejection fraction, how good your heart is pumping out blood. They have certain levels that you need to reach. And lastly, you want to explain BNP?
Yeah, so I think, again, just to highlight, what would be the symptoms if you had heart failure? It would be what we call edema, like fluid in your legs. You push on the skin in your leg, and it kind of stays there like a dent. Maybe you're more short of breath than you used to be. You can't, walk up the flight of stairs like you used to, et cetera. And actually, the first screening test that they recommend now, the ADA, is this BNP, which is it's a lab test, beta natriuretic peptide. It basically tells how stretched out the heart is. And it's a simple lab test that's been around for a while. And if that's high, that is an indication that you need to do some more follow-up tests with like the ultrasound of your heart, et cetera. So it's something to definitely ask your provider about if you have any of those symptoms, but also maybe not, even if it's just like once a year part of your lab test, should I add on this BNP, N as in Nancy, to kind of be screened for it?
And the BNP has been around a long time.
It has been.
And that's what cardiologists follow patients in the hospital with congestive heart failure. But once again, we're trying to get to people early. So you mentioned the symptoms, great, and I'll add on that unexpected weight gain from all the fluid.
Yeah.
Just weak, shortness of breath, ankle edema, and Jeremy said dent, us doctors call it pitting edema. And so it's important to be aware of those symptoms.
All right, so another thing in the field of cardiology or kind of like your blood vessels is something we call peripheral artery disease. So we just talked about the heart not pumping enough, you can get, congestive heart failure. Unfortunately, another thing that people with diabetes are prone to is what we call peripheral artery disease, which is basically, it's usually in the legs, that the blood flow to the legs is impeded. that you can get clots in the arteries, that basically you're not getting enough blood to your leg muscles. And the primary symptom of that is you'll get pain in your legs after walking or exercising. It's usually in the calves that it starts. You used to be able to walk 5 miles or, a mile, no problem. Now it's, half of that. And gosh, I really got to stop and I got to rub my calves, because it's not like a muscle sore, like, after working out. It's like, it's a real crampiness. And that's just a sign that maybe you're not getting enough blood to the legs.
Yeah, and you know what? It's just an extension of what we're talking about with heart disease. But remember that your legs go further away from your heart than any other part of your body, so they get narrowed earlier. And you might develop sores that do not heal. And there are certain tests that a podiatrist can do, that an orthopod with interest in lower extremities will do. They'll put a Doppler on your leg, they'll measure blood flow. There's all kinds of different tests that you can get, but those are some of the important symptoms. And typically, if you have other cardiovascular abnormalities, you should be on the lookout, and it's always good to be preventative.
Yeah. And really the first screening test they can do for this is very easy. They check the blood pressure in your arm, like you're very used to, and they check the blood pressure in your leg. And they look at that difference. It should be pretty, equivalent. But if there's a big kind of drop in the pressure in your leg, that's a sign that like you might not be getting enough of blood flow. Then they can do other procedures. But it's just these things to kind of put in your mind, because so often people will be like, yeah, I've been having that symptom for years, but I thought I wasn't eating enough bananas or whatever it was. I needed more potassium. I don't know. And things can get kind of dismissed. So again, we're not here to scare you, but it's just to let people know. And with all these things, actually, like another huge pillar is if you're smoking, that is just an absolute, that's something that you need to focus on more than anything else. Because cigarette smoking just exacerbates all these things, especially with your blood vessels.
And we acknowledge it's a tough habit to break.
Yeah.
And we would suggest to our patients who smoked, we give them any type of support they need. It's the strongest addiction we know, more than alcohol, more than food. So, we have empathy for that.
Yeah.
And it's a tough habit to break.
All right, switching gears. Topic 4 is actually, we're going to kind of go back to type 1 diabetes and preventing type 1 diabetes. So this is something that we've talked a lot here about TCOYD, that we have an approved medication now to actually help delay the onset of type 1 diabetes. So Steve, this is a huge deal, lots to talk about in this area, but how do you want to kick it off?
I want to say, are you glad you didn't leave early like Jeremy suggested? Jesus Christ.
I didn't say they should.
You said you can go. I heard you say that.
All right, you're right.
Okay.
Well, they won't know if they're
The reason why it is such a big deal, and I'll make this really fast.
Okay.
Over the past 3 decades, they have cured hundreds of diabetic mice and rats. They had big press releases that cure for type 1 is out there. When they tried those cures in humans, they didn't work. So this is one therapy that's been developed over the past 20 years that now is approved by the FDA to give to folks who have what I'll call pre-type 1 diabetes. You can expand. They have the autoantibodies that identify someone that will go on to get type 1. They give it to them. It's a 14-day infusion, only about 30 minutes a day, 14 days in a row. And they have shown that you can delay the onset of type 1 for an average of 3 years. And Jeremy and I think that is huge, especially when you look at all the advances going on with diabetes now. And then the other benefits you'll talk about avoiding that horrific DKA first admission.
Yeah, I mean, the real bottom line is, look, if you already have type 1 diabetes, it's too late for us. This is really about, you need to get your kids screened, your brothers, your sisters, your parents. And what screening means is you can do a simple blood test. This can even be a finger prick that you do at home, that if you have these antibodies, you can be a candidate for this medication to prevent the onset or delay the onset of type 1 diabetes. So how to do that? Probably the best website now is one that's called asktheexperts.org. It's one that's created by people at the Barbara Davis Center, which is the University of Colorado, where you can go on there. You can say you're interested in being screened. You could just send that website again to your relatives, whatever, they can look it up. And there's options there for getting kits sent to your home completely for free. And if they come back with that, some of these antibodies that are indicating that you are at risk for type 1 diabetes, they come back positive, you can actually get treated and help delay the onset. And it's 3 years on average, sometimes more, sometimes less. But we always say it's worth it for 3 freaking days, let alone 3 years.
For many of you type 1s, you remember when you're first diagnosed. You get sick, you're sick for weeks, sometimes months. You end up going to the ER. Many of us were hospitalized in the ICU for diabetic ketoacidosis. And just by screening and knowing you're positive can prevent that whole cascade of emotional and financial stress that you get with a surprise diagnosis. So it's amazing that we have this. It's the first disease-modifying drug for people with type 1.
It's called teplizumab, if we haven't said that, or TZIELD is the trade name, TZEILD. And honestly, this is a difficult medication to get out to the masses because there's some logistical issues. It's not for the patient that I'm seeing in clinic with type 1 diabetes. It's for their family members that I might not know at all. So we really are relying on you guys to get the information out there to identify people that could benefit from this. So please do spread the word about getting screened for your relatives.
Yeah, and 80% of the people that come down with type 1 do not have a family history. So you say, why aren't we screening everybody in the world? Some organizations promote that, but the low-hanging fruit is the people who have type 1, the first and second degree relatives. They get it at a much higher rate. So,
and some countries now are thinking about, I heard that Italy is going to institute kind of mandatory screening at a certain age, like 5 years old or something, for everybody.
For everybody, yeah.
And so we're not there yet at the US, but we might be. So now that we have something to do about it. And by the way, this drug is indicated for people that are 8 years old and older. So it's important to keep in mind. If you have a 5-year-old, 6-year-old, you can absolutely still get them screened, but this medication is only approved for 8 and above. So we've talked about this a lot in podcasts and other things, so there's lots more places to get information on that because it's such an important topic.
Yeah.
So I almost hate to leave it behind, but we got to move on.
Well, we have, like you said, we have podcasts and lots of videos.
Yeah.
Go into the search section of our website.
So topic 5 is on the diagnosis of obesity. So the term obesity has a very formal definition in the medical world. So it's a term that gets thrown around and kind of people in conversation know that person's obese or overweight, but they actually have definitions. And it's historically relied on what we call the BMI, the body mass index, which takes into account how tall you are and what your weight is. And technically, if your BMI is over 30, that puts you in the obese category. Between 25 and 30, you're overweight. You can go online, Google a BMI calculator and look at that. But the BMI has some issues.
Yes.
Somebody could be extreme, like Arnold Schwarzenegger, or I don't know, who's like...
How'd you pronounce that?
Who's The Rock? The Rock, like super fit, muscular guy, would probably technically be obese based on just his height and weight, but it's all, muscle. So, and, if somebody's really, is elderly and very thin, it can kind of underestimate it. So there's some movement to incorporate another measure of health in terms of weight. And what is that?
The waist to hip ratio. And the BMI doesn't do a good job at talking about where the body fat distribution or the amount of body fat. My example is LaDainian Tomlinson. I always talk about that. He's my favorite running back when the Chargers used to be in San Diego. He was fit, and his BMI was 35. So that's a great example of the BMI is not for everybody.
Or The Rock, if you want to be more current,
like
current pop culture.
He's a rock singer?
No, The Rock, like Dwayne The Rock Johnson, like he's a movie star. You know who he is.
Yeah, I know who he is. Okay, anyway, so now how do you measure your waist-hip ratio? There's ways online that will show you. We even have a graphic if we have it.
Yeah.
But basically...
This is actually important because, sorry, I didn't mean to cut you off.
No, please, go ahead.
People generally do this wrong. So this graphic is actually important. You should look it up. But basically, you're going to measure kind of the thinnest part of your stomach, which is usually right at your belly button, a little bit like...
Are you allowed to suck it in?
Well, I don't know. Be as honest as you can. Ideally, actually, you have to have somebody else do this, and then they can really kind of help, which, let's be real. This is a little awkward. Nobody likes to have their stomach and waistline measured, but this is a very easy to do thing and easy to kind of follow. So you get your kind of thinnest part right around your belly button.
Right around the belly button, yeah.
Shown there. And then kind of the widest part around your hips. And you can do that in inches. And then there's calculators online that Eric has, I think, an example of here that I think I just put in, 36 inches for one and 40 inches for the other. And it spits out this ratio, in this case of 0.9. So the definition of obesity based on this hip to waist ratio for men is anything over 0.9 and women anything over 0.85. So why are we talking about this? Well, we just want to help people identify when weight is becoming a particular issue. I hate to say that. You can use the BMI online. You can do this waist to hip ratio.
Do them both.
But if you are in this obese category, this is not just an aesthetic issue. This puts you at higher risk for multiple issues, heart disease, actually some kind of cancers, all these kinds of things. And it just might kind of bring it more to the top of your to-do list to really address this. And we can talk about how to do that next with medications, et cetera.
Yeah, and this topic of obesity pertains to type 1s and type 2s. Mm-hmm. Jeremy always points out type 1s aren't all skinny mini anymore. Mm-hmm. And obesity has so many negative associated conditions. It is so important. Mm-hmm. And our society is getting heavier for lots of reasons. So less exercise, the things we eat. And so it's treating obesity is also an inherent area where we focus in on type 2. Now, we always describe type 2s. Many doctors at doctor meetings say, people with type 2 have a very high waist to hip ratio because they have that abdominal pannus, and that's from intra-abdominal fat. Sorry to get too scientific on you, but I do want to get some respect that we're doctors. And Eric, the guy's still laughing. No, it's true. It's the big, beer belly kind of look. And that is a type of fat that's highly associated with cardiovascular issues. Mm-hmm. But so I can see why the waist hip ratio might be beneficial. But once again, you might have a family history that everybody in your family has a certain waist hip ratio with, maybe narrower waist, and that messes up your average. Mm-hmm. So I would take everything together, your BMI, your waist hip ratio, look in the frickin' mirror, and you could tell, how your body weight's doing.
Well, if you're listening to this, you probably have diabetes, and it means you're probably overweight. So about 90% or more of type 2s are either overweight or obese.
Type 2s, yeah.
Yeah, and 2/3 of type 1s are either overweight or obese. So the majority, whether you have type 1 or type 2, is dealing with weight in some way. Maybe you need to lose 2 pounds, maybe you need to lose 20 pounds. But this is an issue that, and not just people with diabetes, but Americans, kind of struggle with. So how do we lose the weight? Well, we can't forget about good old, diet and lifestyle. These medications are very effective, and we'll talk about it. But making sure you're on, some kind of dietary plan, you're exercising. The goal is 30 minutes a day, 5 days a week. A very aggressive weight loss plan is about half a pound to a pound a week. So that is really important to set those goals and kind of march those out. That if you wanted to lose a pound a week, which would be a lot, it's going to take you a couple months to lose those 10 pounds. It can't be like the wedding's on Saturday and diet starts today, kind of thing.
Yeah, you have to be patient. Yeah. And I always find that for people, they can get motivated and lose weight with a normal lifestyle modification, but it's so easy to gain it back. And there are good phone apps. You put in your weight, your goal, the time that you want to lose it, and it tells you how many calories you need to reduce in your typical diet a day. Because it's 3,500 calories is 1 pound. That's 500 calories a day reduction. Mm-hmm. That's a lot.
Yeah.
So that's why one pound a week is a lot. So we love to skip to GLP-1s right now and talk about weight loss, but you need the basics, and you have to develop lifestyle habits over the long term. It's the age-old problem. Once again, you look at the degree of obesity in this country and around the world, in developed countries, it's going up. Mm-hmm. And along with that is all kinds of other metabolic and other conditions.
So then transitioning to the medications, you'd have to be living in a cave not to have heard about Ozempic. Everybody's on it. And then Mounjaro, we talk about as another one, Trulicity. There's lots of good options in this class of drugs. And I would say, something new to talk about perhaps is that if you have diabetes it generally makes it much easier to get these medications. We actually just had a whole endocrine division meeting an hour ago where we talked about these huge issues of getting these medications. One is getting them through insurance, and the other one is actual supply of whether it's available at the pharmacy or not. But in terms of insurance, it's much more difficult to get these drugs approved just for weight loss if you don't have diabetes. You have to document that you're going through a weight loss management plan, that you've been doing this for 6 months, et cetera. If you have diabetes, it's much easier. Now, I'm using the term diabetes to mean kind of type 2, but type 1s can get these medications. They absolutely work in type 1s in terms of weight loss and in blood sugar control. So your provider can try to put in things like, this is insulin resistance, or if you're comfortable with it, kind of double diabetes. I see a lot of patients that are type 1, they got it when they're 5 and now they're 50 and they're overweight, they're using huge amounts of insulin. They have a family history of type 2 diabetes, and in that case, I think these people probably would have gotten type 2 diabetes if they didn't have type 1. So you kind of can get both. The point is that type 1s can, get these prescribed, and you can also just try to use them for obesity or weight loss. So these are becoming more available to type 1s also.
Yeah, my approach is when you do the prior authorization, the request, you do not use the word, if you're a type 1, you do not use the word diabetes.
Like insulin resistance or like metabolic syndrome,
Yeah.
something like that.
And so you just focus on the obesity, and remember that your BMI, they still go on BMI, not waist to hip yet. If it's over 27 or greater with risk factors, so if you have diabetes, that's a risk factor, but your heart disease, your family history of heart disease, high cholesterol, abnormal blood pressure, those all go on the list. If your BMI is over 30, I don't want to say you're golden, but you're in the category that you'd most likely get approved. But if you have type 1, do not use the word type 1 on any of the paperwork or the requests.
Yeah. And then if you're having issues actually literally getting these medications, pharmacies out, ask your provider or the clinic staff, hey, have you heard about pharmacies that have more of a supply? We kind of at UCSD funnel people different ways. Or take it upon yourself, literally call around.
Yes.
These places are not unfamiliar with people calling and saying, hey, do you have Ozempic? Nope, sorry, next, okay? Go through it and find one, and then you can have your provider kind of like prescribe it there.
For us in San Diego, a lot of folks go to pharmacies in Mexico. So anywhere you're near a border, even Canada, you can get it much less, for much more affordable.
So again, we could talk about weight loss, weight management all day long. We have on our podcast, you can search that on our video vault on our website, just like dedicated talks to just this.
Can I say one more thing?
Absolutely.
Okay. As a doctor, I get people to tell me all the time, do I really have to take this drug forever? This is what I say to them. You want to take this drug forever. It's going to help you keep the weight off. Research shows they stop it, people gain the weight back. You want protection of your heart, your kidneys, your bones, so many other areas, your liver. You don't want to stop this medication. Stop other things, but don't stop your GLP-1. That's an important point because a lot of people don't want to take prescription drugs.
Yeah, and I think you guys know this, but it's worth saying again, your provider gets zero kickbacks from this. If everybody listening to this goes out and gets Ozempic, we don't see a dime from that. So we're not trying to promote general drug use.
Rich.
Yeah, it's like this is best practices. We think I think people with diabetes in general have an opportunity to use these medications. Is another way you're saying it.
Yeah, and it's a medication that has changed the way we treat people with type 2.
Exactly. So
tremendous.
Topic 7, because we got just a few minutes. So let's go through these in kind of like rapid sequence to get to people's questions. Is updates on hypoglycemia, low blood sugar. I would say that the biggest kind of advance there, which again we've talked a lot about, is advances in glucagon. And everybody who's on insulin, or if you're type 2 sulfonylureas, if you have any history of hypoglycemia, you need a current prescription for glucagon. And it used to be those red kits that you had to mix and, like they expired 14 years ago and you've got it lying in some cabinet that nobody knows about. Now they come pre-mixed. You got the Gvoke pen from Xeris. It's like an EpiPen. It's already mixed. You can just push it down and it auto ejects. Good for 2 years shelf life. Bacsemia is a nasal one, also good for 2 years. Make sure you have an active prescription of glucagon, one of these, and make sure somebody that you know knows how to use it. It's no good if, I pass out right here and nobody knows where the glucagon is. Know where it is, show your family member, your roommate, your loved one how to use it, and that's my spiel on glucagon.
Yeah, nothing to add. Want to keep going, but we have a podcast for you type 1s where teach people how to use mini dose glucagon. That's the teaser.
Oh yeah, that is a good one. Little doses just to, help with exercise, etc. All right, topic number 8, fatty liver. So this is kind of a buzzword. Maybe you've heard a lot about this, that anybody that's struggling with weight, but particularly people with type 2 diabetes, just like we get fat everywhere else, you can get fat in your liver. And that can cause inflammation. It can ultimately lead to kind of liver failure,
fibrosis,
all these kinds of things. So I found the stat that it can be present in over 70% of people with type 2 diabetes. And they're actually recommending now this new screening lab that's based on labs that you normally get. Your chemistry values, your liver function tests, your age, and your platelet count. It's something that's going to be part of your routine labs. But based on those, there's a calculator that your provider can use to see if your liver function is in a concerning level or not. And if it's not, great. But if it is, then you can have, these other procedures done to see if you have, like ultrasounds, to see if you have fat in your liver. So again, it's not to scare people. Gosh, I got to get screened for heart disease and liver disease. It's just to be aware that these things all run together. And so having kind of sophisticated conversations with your provider, maybe you've got your blood sugars under control. Hey, I'm good on these medications. Tell me about fatty liver. Tell me about, congestive heart failure. What should I be worried about?
Yeah, typically a provider will look at the chemistry panel. They'll look at these two tests, the ALT and the SGPT, and they'll say they're elevated. Those are your liver function tests. But I think this easy calculation for platelets, which is part of your complete blood count.
It's called the FIB-4, before I forget, FIB-4.
Does The Rock sing that song?
Oh,
The
stop.
FIB-4?
I'm going to show you a picture of him, and you'll be like, oh, I know that guy.
But I'll say this, that people say, healthcare professionals say that the need for liver transplant due to fatty liver is going to be the single greatest cause for the need for a liver transplant. So it's important to just ask your provider, especially if there's any abnormalities on your chemistry panel. There's ways to make a diagnosis, including scans, and the ultimate is a liver biopsy, but hopefully you wouldn't need to get that far. And a lot of the medications we're talking about, like GLP-1s, can help improve those.
Yeah.
And there's a brand new medication. How do you pronounce that one?
Well, I was going to say first, so, the good news is if it's fat in your liver, just fat in your liver, it's completely reversible.
Yeah.
And the number one treatment for it is weight loss. So when you lose weight, you kind of lose fat everywhere, including your liver, and it's kind of just detoxifying if you think about it. So these drugs like GLP-1s, you lose a significant amount of weight, can be very good for your liver and just your general health in general. So you added this new medicine, so you pronounce it.
Yeah, well, let me just take a look at it.
So Rezdiffra.
Rezdiffra, you know these names. Basically, this is the first drug that specifically targets fatty liver disease that is associated with fibrosis and inflammation past the fatty stage. So it's kind of it's a good point in time for people that may have liver disease, because there are other drugs being developed. This is the first one approved in March of 2024. So it is kind of exciting. You can relate that to TCOYD for type 1 prevention. This is for fatty liver disease prevention, especially if you have fibrosis. So there is progress in that stage, and I think the new standards of care is telling healthcare professionals, you got to look for this stuff.
Yeah. And you're probably getting a sense that there's a lot for providers to keep up with. And so you can't be too hard on us, like if things get through the cracks. But a better way of saying that is you need to be empowered of, hey, here's something that I really am interested in screening for, I'm concerned about. I heard on this fantastic podcast with this one really good looking guy and this other I don't know, 6. Just kidding.
Some older guy.
Anyways, to bring up with your provider. So topic 9 is diabetes technology.
Yeah, I can just summarize this part. They are telling the world of healthcare professionals, nurse practitioners, PAs, MDs, that you need to get up to snuff on the technology. You need to learn about the G7, the Libre 3, the Eversense 6-month sensor, the Medtronic Guardian. You have to know something about these hybrid closed loop systems. Control IQ. I mean, there's a whole bunch of them.
Yeah.
And they have to have some level of knowledge, because if they don't, they'll never even recommend it to you as a patient. And that's why empowerment is, you're going to be knowledgeable, and you're going to make the suggestion. And hopefully they're a good enough doctor to say, hey, I'm not that familiar. Let me look,
Yeah.
let me read up on it.
I mean,
It's just a big move for the ADA is to slap doctors around and say,
Yeah.
please learn about technology.
yeah. And thankfully for type 1, this is a well accepted part of standard of care. Continuous glucose monitors and pumps. People not be that familiar with the different systems, but this is now happening with type 2s. Now, there's been a big resistance in kind of using continuous glucose monitors in type 2s, but that is happening now. That if you have type 2 diabetes, especially if you're on insulin, you can get this approved. They're moving to getting this like over the counter now, continuous glucose monitors. It's just going to be becoming the way that we measure glucose. Just like, finger sticks, now it's just going to be like people just use continuous glucose monitors.
Yeah, I'm glad you mentioned the one that's over the counter. So there's going to be two over the counter. Dexcom has one called Stello, and it's not for people on insulin, but they believe, and we believe, that the CGM for people not on insulin could be really valuable. And it's going to go 15 days, no alerts and alarms, because you don't need them. You're not on insulin. And then Libre folks, they have one called the Lingo. And I don't know what form that's going to take, but it'll be similar. And pretty soon these things will be everywhere. And people are using them. It's a fantastic behavior modification tool.
But yeah, again, not enough we could say about technology. We just did a podcast with David On, one of our previous coworkers, colleagues, on all the different systems. So if you want to kind of a little bit of deep dive on that, and then we did a
live
program with him, just like was it our last live that we did? That was
Two ago.
Okay.
And yeah, it's all on our website too.
So the last topic is bone health, and we'll go through this kind of quickly. Bone health.
That's
in
new.
People with diabetes. This is new. And again, added to the list, people with diabetes, both type 1 and type 2, are at higher risk of fracture. And this can be up to a 50% increase in people with diabetes. And people with type 1 also. So the thing that it's saying is that everybody over 65 should be screened for your bone density. That's a DEXA scan. It's basically a kind of sophisticated x-ray, but very easy to get done. So if you're over 65, you have diabetes, men and women, like kind of historically, bone health has been focused on women because they are at higher risk, but men also. And then probably earlier if you have type 1 diabetes. So maybe even after the age of 50, because obviously type 1s have been living with this longer, to get screened, ask for a DEXA scan. And the most important thing that I didn't know until, again, we did this podcast on bone health with Dr.
Good
Woods,
podcast with a bone specialist.
is that the results of the DEXA scan can be a little misleading in people with diabetes. They can give you a false sense of security that you're in the normal range, but if you have diabetes, sometimes a normal result can be abnormal. It's a little bit complicated. So you need somebody to interpret your DEXA scan that is kind of sophisticated in bone health and determine if you need to go on medications to avoid fractures, et cetera. But again, this is a brand new section of these, well, it's been expanded in these diabetes guidelines to bring people awareness to this is something else we need to be looking at, all with the effort of prevention, right? That we want to catch these things early so you don't have a hip fracture that comes out of kind of nowhere, that you can be screened for it and prevent it.
Yeah. And what I learned yesterday from Dr. Woods, we were in clinic together. She pulled up a DEXA scan, and you can get a lot more information. You can get really accurate information where your body fat is, what percent of your body is lean muscle, and it compares it to what it should be. So they're not expensive at all, and most of the time it's covered by insurance.
All right, let's try to get to some of these questions as quick as possible. So that was 10 topics that you guys just got you're up to date. And kind of the latest and greatest in diabetes, management and things like that. So
make sure you follow us on
everything. Like us,
love us.
Yeah.
Oh, wait, share us too. So, yeah.
Okay. So how do daily fluctuations in A1C affect organ health? So I assume this means kind of fluctuations in glucose. So there's been a lot of look at, is it just the A1C, your average blood sugars, or what if I'm having more highs and lows and fluctuating more throughout the day? In general, it's more about your average blood sugar, your time in range. We try to reduce the fluctuations as much as possible. But I think the take home here is that we all, especially as type 1s, will have like those over 200s, usually on a daily, basis. And you get your blood sugars back in range, and you don't worry about like that just blew up my eyes or my kidneys or whatever. We all have those fluctuations.
I totally, totally agree with that.
Yeah. How does type 1 contribute to cholesterol? I don't know if having type 1 per se makes your cholesterol levels different. However, having type 1 diabetes puts you at a higher risk of having heart disease. So we are more aggressive with treating your cholesterol levels because of that.
But if you have type 2, it's a different story.
Yeah.
People with type 2 have high triglycerides, low HDL, and HDL is the protective cholesterol. So that's a certain type of what we call dyslipidemia. And so type 1s are different from type 2s, and everyone needs a good fasting lipid profile and a caregiver that knows how to deal with the abnormalities.
So how often do I need to replace my Gvoke? That's one of the glucagon things. It has a shelf life of 2 years, right?
Yep.
Okay. So medication questions of these GLP-1s and SG2s. So if these are now first line for type 2 treatment, have payers stepped up to cover these better? Well, in general, I would say that yes, if you have a diagnosis of type 2 diabetes, that payers are paying for these, that, let's say that somebody prescribes it first. Sometimes they might say, has the person been on metformin or tried it? And the provider could say like, they tried it and it didn't work, or I want to use this first. But I actually don't see those questions hardly at all anymore. When I prescribe these medications, especially the SGLT2s, which are pills, they get covered.
Well, you know what? I feel your pain. All insurance companies are different, and some are tighter than others. But just to clarify, the ADA recommends using these first if you already have a heart attack, stroke, or congestive heart failure, or with renal insufficiency with SGLT2. So, that's when they say you should go to these first. So most of the time, by the time we see patients, they've had type 2 for a while, they're fed up with their usual doctor, they heard about us, they want to come see us. And so for us, it's never a big issue. They're already on metformin. So I would say that you need to just push, and I agree with Jeremy, these companies are getting more lenient. SGLT2s are not in short supply, and they're cheaper than GLP-1s, and they're super protective. So they work great together, by the way, too.
Yeah. Okay. So when will GLP-1s be approved for type 1s? It's going to be a while. I would say my goal would be 5 years from now. That the current, drugs, Ozempic, Trulicity, they're not studying them in type 1 diabetes, but there's some new companies developing ones that actually are, but it's going to take some time. So approved just means that they've done the studies in type 1 diabetes. We know they work, they just haven't been formally studied, which means that insurance companies generally don't cover it or are more resistant to it. So your provider can absolutely prescribe it, you can absolutely take it. It just comes down to the insurance coverage when it comes to being approved.
Yep.
Okay.
I can answer that question. Someone says, can you take Ozempic, a GLP-1, or Farxiga and metformin all together? The answer is absolutely yes. And it depends how you're doing, how your A1C is doing.
And they're saying, can I discontinue metformin? Well, I would talk to your provider because the metformin works very well. It really is effective in lowering blood sugar. So if you stopped it, you probably would see a bump in your blood sugar.
Yeah.
So recommended screening age for type 1 diabetes is 42 old. No, you can get it done at any age. You can get type 1 diabetes at any age. Could screening be done at birth? Yes, it can, but that's a little too early. There's actually a peak in when people get their antibodies like positive around age 2 or 3. So generally you'd probably want to wait. If you had to pick like one time to screen people, it'd probably be in that like 2 to 5 years old kind of range. Does insulin increase weight? Where I inject seems larger. Well, that's two different questions. So where you actually inject insulin, especially if you do it in the same exact spot over and over, you can get local, what we call lipohypertrophy, where you get just kind of like a fat deposit right there. However, insulin itself, I suppose, can increase weight, especially if you're on too high of doses, if you're having more low blood sugars you're having to eat out of, it's impairing your ability to exercise, etc. But I don't want to put that idea in your mind, because if you're on insulin, it's very effective and likely needed to control your blood sugars.
Yeah, we know in type 2s, it's the nature of the beast is some type 2s need insulin. And we give insulin in a very non-physiologic manner. We inject it into Jeremy's lipohypertrophy. And it's not the way a normal, healthy person's pancreas works. So it goes right into the bloodstream. So when you give insulin through the subcutaneous tissue, you might need more than you normally would if you didn't have diabetes from your pancreas. And that does cause some weight. And weight gain is usually directly linked to the amount of insulin you're on. But as Jeremy said, we got to keep your blood sugars normal. That's goal number one. But you don't want to be on excess insulin.
Yeah. I'm on losartan and amlodipine. My blood pressure still is high. What do I do? Well, this pertains to anybody that's their blood pressure is still high. There's a number of medications that you can use, and it can often take 3, if not 4 different medications. So in this particular case, this person's not on a diuretic. Something like hydrochlorothiazide is something we commonly use, but definitely talk to your provider because the list is long. In terms of combinations you can do and safely use together to control your blood pressure. Do you have any comments on that?
No, I'm going to the next question. Someone wanted the name of that liver drug
How do you
again.
spell the medication?
You ready for this? REZDIFRA. And don't ask me where this name came from. But if you just type into Google, new drug approved for fatty liver disease, it will come up like that.
All right, this is a good one. When will Medtronic's Simplera get approved? So Medtronic has their 780G system, which is a really good pump hyperclosed loop system that frankly uses kind of an antiquated sensor. The Simplera is going to be much easier to use, more in line with kind of Dexcom, et cetera. They've been using it in Europe for a while. It's supposed to be approved here.
I do not know, but
Soon.
it's at the FDA or on the way to FDA, and it is a big advance. Their current 4th generation sensor that goes with the 780G now, it's very accurate, but it doesn't have the form factor of the Simplera, and that's
So hopefully soon. Trust us, we're all waiting for that. So is history of low blood sugar linked to memory loss? I would say no. That kind of like routine low blood sugars.
What was the question again?
Or lows. Certainly like more significant if you have a history of like multiple seizures, losing consciousness, things like that can impact kind of overall brain function, et cetera. But they've looked at this long term in kids that have had multiple exposures to hypoglycemia. Do they have long term detriments in their kind of overall mental health, Alzheimer's, things like that? And the answer generally is no. That doesn't, thank God, doesn't have a long term effect.
Yeah, a lot of people ask that question, and we feel your pain, but a lot of lows that aren't severe, that do not cause you to become unconscious, they do not have any long-term damage.
Yeah.
And you just need to avoid the serious ones, and that's why everyone should have glucagon around when they need it.
Well, I think that's pretty much it. So thank you so much, everybody, for watching. This, I would say, went slightly longer than usual. We're right in an hour, but gosh, there's so much to cover. And please do visit our website. Again, look for our podcast anywhere that you listen to podcasts for deeper dives on essentially all these topics. And then we hope to see you on May 4th. We hope to see you in person at the One Conference, and definitely at the next live event we do.
Yeah. Today's program, thinking about it, this is information that will literally save your life. Or the life of someone you love with diabetes. And it'll be endearing on our website. And you can always go on, and we have blogs for all the different articles we do. So feel free to go on and ask questions. And don't forget to like me, share Jeremy, and follow both of us.